Hello and welcome this evening to our monthly health talks, community health talks, brought to you by the Center for Asian Health Research and Education at Stanford, in partnership with the Stanford Health Library. My name is Bryant Lin. I'm on the clinical faculty at Stanford, and I am co-director and co-founder of the Center for Asian Health Research and Education, CARE for short. We're very pleased to welcome you the second in our series of monthly health talks, brought to you by CARE. We have the great pleasure of having Dr. Kebi Josan here with us today. She will be talking about heart disease in Asians. Kebi Josan is a general and preventative cardiologist at Stanford and the clinical lead of the South Asian Translational Heart Initiative, SATHI. She completed medical school at the University of Western Ontario, followed by internship and residency at the University of Alberta. She then went on to complete cardiology fellowship at the University of British Columbia in Vancouver, Canada. Dr. Josan is passionate about primary and secondary prevention of heart disease. She has extensive experience working with high-risk South Asian populations. Her research interests include cardiovascular disease prevention, lipidology, and insulin resistance. She is also interested in the use of digital health technologies to enhance lifestyle modification programs. She was pivotal in the launch of CardioClick, an innovative telemedicine program in cardiology, and the platform that Stanford Healthcare has adopted for video visits during the COVID-19 pandemic. Please join me in welcoming Dr. Josan to give our monthly talk. Just a brief note to the audience, the talk will be approximately 45 minutes, followed by a question and answer session. You can submit your questions in the Q&A below. Welcome, Dr. Josan.
Thanks so much, Dr. Lin. I really appreciate it. And it really is a pleasure to be here tonight. I appreciate the opportunity to speak to the Stanford community about a topic that is so near and dear to my heart. And so as Dr. Lin mentioned, I am one of the preventative cardiologists here at Stanford, part of the faculty at Stanford. And I deal with, all sorts of general cardiology conditions, but one of my passions is prevention, both in the primary capacity, so primary prevention of coronary disease, so patients who've never had an event, and also secondary prevention, so those patients who are high risk because they've already had a cardiac event, and we work closely with them to try to really lower that risk. I work with high-risk South Asian populations as well, and that's kind of my expertise. So I will be talking to you about heart disease in Asians in general, and then I will talk in some detail about South Asians as well. So the outline for our talk today then, I'm going to start off by letting you know a little bit about heart disease and what you need to know about heart disease, as well as the risk factors for heart disease. Then we will talk about heart disease in Asians in general. Following that, I will talk to you a little bit about heart disease in South Asians. And then I will share some tips on what I think you can do to prevent heart disease yourself. And then if we have some time, I'll touch on a few common questions that come up in clinic when I see patients, and then we'll go through our question and answer. So heart disease. Well, according to CDC, heart disease is the leading cause of death in the United States. Heart disease causes 1 in every 4 deaths in the US, and every 40 seconds, an American will have a heart attack. So to put this into perspective, over the next hour that we spend together, about 90 Americans will have already had a heart attack. What do people mean when they're talking about heart disease? Well, it is a term that can refer to a number of cardiac conditions. The most common, and I think what most people usually refer to when they think about heart disease, is coronary artery disease or hardening of the arteries. There are, however, other conditions like heart failure, where there's a problem with either the pump function of the heart or the heart's ability to relax. There are other cardiac conditions like arrhythmias or problems with the electrical system of the heart, and valve disease. But for today's talk, I'm going to be focusing on coronary artery disease. So what is coronary artery disease? Well, this is a picture of a coronary artery cut in cross-section. And so I'm going to use my pointer here, but what you can see is that this is the different layers of the artery. And on the in the inner lumen of the artery, you're starting to see plaque forming. So this is usually a buildup of cholesterol. Over time, this progresses, and this is where your cardiovascular risk factors and the management of them becomes really important, because if we don't manage them well, this continues to progress. It can progress to the point where the blood flow becomes quite tight. And, we have fancy ways in the cath lab of trying to assess whether something is tight enough to be causing a problem. But generally, we say if an artery is stenosed by about 70% or so, it's enough to cause patient symptoms. So you probably have heard of people who have angina, who go for walks, and they either need to take their nitroglycerin or they stop and rest when they have chest pain. And then, of course, there's the other extreme of heart disease, of coronary disease, when this plaque becomes unstable. So when plaque rupture happens, what usually happens is the body, trying to heal the damage, sends clotting factors and platelets to the site, and what ends up happening is that the artery can become completely occluded. So that means there can be a complete blockage of the inside lumen of the artery, and no blood gets past that blockage. So you can have damage to the heart muscle and death of heart muscle. So now that we know a little bit about what heart disease is, let's talk a little bit in general about the risk factors for heart disease. So if you've ever seen a cardiologist, or if you've gone to see your internist and they're trying to, predict your cardiovascular risk, these are the things that they're probably going to ask you about. Whether or not you have hypertension. So that means, do you have high blood pressure? And I will say that, having an awareness of what your blood pressure is really important. Over time, our targets for treatment have changed. And whereas in the past, we didn't treat until people got to blood pressure sort of in the 140/90 range, for many years now, we've been treating blood pressures when they get to 130/80. And I think people's perception of what is normal is often skewed. And so you should realize, even if you have blood pressures that kind of run in the 120/80 range, that is already a stage, what we call, or a stage that is called pre-hypertension. And other important cardiovascular risk factors are hyperlipidemia. So if you have high cholesterol, diabetes and sugar problems, smoking is a big modifiable risk factor. And then, of course, your family history. So we usually spend some time taking a detailed family history because there can be a genetic predisposition to developing heart disease. Now, with respect to hypertension, this is something that is often referred to as the silent killer. And the reason is that unless you check your blood pressure, you often will not know if your blood pressure is running high. There's about 67 million Americans, at least in 2012, that were diagnosed or had high blood pressure. That was at the time about 1 in 3 adult Americans. Out of those, about 53 million were aware. So a little less than 80% actually knew their blood pressure was high. Even less of those were treated. So a little over 60% were treated for their high blood pressure. And shockingly, less than 50%, 31 million, had controlled hypertension. So there is a lot of opportunity for improvement here, as you can see. With respect to hyperlipidemia or high cholesterol, this is also a very common problem that we see in our American population. So when you look at sort of above healthy levels of cholesterol, or a total cholesterol level of over 200, more than 102 American adults over the age of 20 have above healthy levels. If you are looking at higher levels, high enough that we think this person would be at increased risk for heart disease, we're looking at numbers sort of in the vicinity of 35 million Americans. Now, your cholesterol in your body comes from 2 sources. Your liver makes cholesterol, but an important source is also from the foods that you eat, and these are usually from animal products. So this is where meat, poultry intake, and dairy intake lead to elevated cholesterol. There are also some tropical oils like palm oil and coconut oil that have saturated fats that can increase your bad cholesterol or your LDL. What other risk factors are important? Well, diabetes and prediabetes. So we really do have an obesity and diabetes epidemic in this country right now. Over 1 in 10 Americans do have diabetes, and the vast majority of those, 89% of those, are overweight. If we look at how many people have prediabetes or a precursor stage to diabetes, it is much larger, 88 million, or 1 in 3 Americans. And the problem is that the vast majority, again, 90% or 80 million, don't even know that they have this prediabetes. Now I'm going to present a few stats here as we go along about different ethnicities, but I want you to take this with a grain of salt, as I'll talk a little bit more about the data with Asians. So when we look at new diabetes cases, they're felt to be higher amongst Black individuals and individuals of Hispanic origin, and actually lower in Asians and people, non-Hispanic whites. But we'll touch on this again. So why do I point out prediabetes? This is something that, I think I want to raise some attention to, because I will say that I encounter patients all the time in clinical practice who have no idea that their sugars have been high or that they've had prediabetes for many years. And I think part of the problem is how we as a medical community present this to patients. We say, oh, your sugars were a little high. Don't worry, you don't have diabetes. But the problem is that prediabetes itself is an important risk marker. So if you look at this graph, on the y-axis here, we have percent survival. On the x-axis, we have time to a cardiovascular event, so a heart attack or stroke. And so what you can see is that the diabetic patients, the ones in red, have the lowest percent survival, or that means the lowest freedom from having a heart attack or stroke. The people with normal sugars in the blue are least likely to have these complications. And then the patients who have one of these precursor stages to diabetes, or something called impaired fasting glucose, are somewhere in between. There's actually also other interesting studies that have looked at the coronary arteries of people who have diabetes, people who have prediabetes, and people who have normal sugars. What they've done is done CT scans in these patients and looked at how much hardening of the arteries is visualized and how much corneal calcium is evident. And again, similar to this graph, it's a very similar relationship. People with diabetes have the most hardening of their arteries, the most calcium built up in their heart. People with normal sugars have the least. And then people who have borderline diabetes or prediabetes are somewhere in between. So if you get diagnosed with prediabetes, then I would say this is an opportunity for you to really take some action. It's not something that should be ignored. I mentioned the obesity epidemic in our country. So almost half, if you can believe it, of the American population, 42% in 2017 was obese, defined by a BMI over 30. And the problem is that these rates continue to increase. So if you look at the numbers from 1999 to 2000, the rate of obesity was about 30%. And by 2017 to 2018, it had increased to 42%. If we look at the rates of severe obesity, those almost doubled, those did double in that time frame. Now, this problem of obesity starts early in age. So if you look at even young adults, people between the ages of 20 to 39, already 40% of them are obese. And then the rates go up slightly as people age. Again, I'm going to present some ethnic specific data here, but keep this with a grain of salt. So Black adults have the highest rates of obesity in the United States, followed by Hispanic individuals, and then white individuals, and Asian adults seem to be the leanest, according to the data. Another important observation is that a lot of these risk factors are presenting earlier and earlier. So if you look at US children between the ages of 12 to 19, already we're starting to see a lot of cardiovascular risk in these groups. So, if you look here in the middle of this graph at a healthy diet score, how many individuals between 12 and 19 got a healthy diet score? Well, you can almost not see the green or the healthy range. It was 0.5%. Almost everybody had either an intermediate diet or a poor diet. If we look at things like physical activity, only about a third of young individuals or young children or adolescents are getting enough physical activity, defined as 30 minutes a day, 5 days a week. The rest are either getting, intermediate or poor levels of exercise. Again, if we look at problems like obesity, we're not seeing as many children that are obese, but certainly there's cause for concern here when only 2/3 of children are in an ideal body weight, and the rest are, in a overweight or obese category. And then hand in hand with these diet, physical activity, and BMI come these other risk factors that I've already spoken to you about, the blood pressure, the cholesterol, and the sugar. So it's not surprising that if these populations are overweight, not moving, not exercising, that they're developing a lot of these other risk factors. So now let's shift gears a little bit and talk about heart disease in Asians. So why even look at rates in Asians? Well, I think it's important to realize that the risk of heart disease death really differs by race and ethnicity. Also, Asians comprise 60% of the world's overall population. So more than 4 billion of the 7.7 billion people in the world are Asian. And in the US, Asians make up 5% of the population and more than 22 million people. Asians are the fastest growing ethnic group in the US, and they're expected to grow to 10% by 2050. But despite this rapid growth, there's really not a lot of information about Asian American health and healthcare utilization. Now, there are a number of reasons for this, and you can imagine that if you only make up 5%, for example, of the American population, when people are designing studies or conducting randomized control trials, you're probably going to be a small proportion of the people in those studies. So, for example, if you design a study and it has 100 people, you may only have a handful of Asians. So it becomes hard to make meaningful conclusions when you have such small numbers represented in trials. Another issue is how we collect and report data in the United States. So in 2011, CMS, which is the US Centers for Medicare and Medicaid Services, started to incentivize hospitals and healthcare organizations receiving CMS funds to start obtaining race and ethnicity information about their patients, as well as language preference. And the idea was that if you can collect this data, maybe you can start to understand healthcare disparities and work on these. So a good aim or a good goal. The issue is that CMS deemed this single Asian race categories as acceptable for recording and analyzing the electronic health record. And you can imagine that we're clumping together people of a lot of diverse backgrounds. So, I told you that Asians make up, in the world, at least 60% of the world's population. So Asian Americans are representing those 60% of the world's population. So these are people from very diverse backgrounds, different cultural backgrounds, different ethnicities. They speak different languages. They eat different foods. They have different migration patterns to the United States, and they have different socioeconomic factors that affect their lives. So you can imagine that if you're clumping all of these people together, you may lose a lot of the details that become important when you're actually trying to understand health differences. So now that I've said that, you may question some of this data, but let's look at it. What data we have from the government in terms of heart disease risk in South Asians. So again, these figures here show you the 4 ways that people have been classified: Blacks, whites, Hispanic, and then Asian or Pacific Islander. The top graph shows you the age-adjusted death rate over the years for heart disease by race. And, you can take there's a few take-home points from this. One, there's some good news in that all of these curves seem to be decreasing. So even though heart disease remains a really important cause of death and leading cause of death in the United States, mortality from heart disease is slowly decreasing over time, probably related to some of the better medications that we have, and also related to public health campaigns educating people about their risk and their cardiovascular risk factors. The other take home from this is that if you use this categorization of race, Asians seem to be faring actually quite well. So if you look at, again, heart disease death rate, Asians and Pacific Islanders seem to be the lowest, and Blacks are the highest, whites and Hispanics somewhere in between. So that was death rate. If you're looking at the rates of coronary artery disease in general in these populations, not just mortality or death rate, again, Asians seem to fare quite well at 6%, almost half of non-Hispanic whites, which was 11.5%. So I've mentioned to you that the term Asian includes individuals from very diverse backgrounds. And I think part of the problem when we're analyzing some of this data, like the data that I just showed you from the CDC, is that when you aggregate Asian American subgroups, you mask really meaningful differences in health and health risk. So if you look at data that provides some more granularity, epidemiologic data, there's data that have shown that there are certain Asian subtypes that are actually higher risk than non-Hispanic whites, in particular Filipinos and South Asians or Asian Indians. And then there are other Asian subtypes that are considered to be lower risk for heart disease, for example, Chinese Americans. Now, there's another factor that kind of makes studying these populations challenging. So when I talk about the care, the health of Asian Americans, these are populations that have migrated to the United States from their native homeland. And so when you think about trying to study them, you might say, well, if we don't have a lot of data in Asian Americans, maybe we can just go back to the data of, that looks at outcomes of these people in their native homelands, Indians in India, Chinese in China, for example. The problem is that when people migrate, they take over, they adopt a lot of lifestyle and cultural practices of their new homeland. And so the data from the area they migrated from no longer necessarily applies. There's good data, for example, in the Japanese population to suggest that, Japanese are traditionally had higher stroke risks than non-Hispanic whites. Over the years, they've really made a difference and decreased their stroke risk. I'll talk about that a little bit. But as Japanese have migrated to the United States, although their stroke risk has gone down because their blood pressure has become better controlled, they've adopted Western lifestyles and Western diets, and their cholesterol goes up. And so their heart disease risk goes up compared to Japanese living in Japan. Now, this is a busy slide, and the main reason to present this to you is show you that there are some small studies that have looked at different Asian subtypes and look to see if there's a difference between these groups, or are we, is it reasonable to clump all of these people together? Well, I think you already know the answer because of the way I'm asking the question, but if you look at different ethnic groups here, so Chinese, Korean, Japanese, Southeast Asian, Filipino, and South Asian, and then different cardiovascular risk factors along the top here. So diabetes, hypertension, coronary artery disease, obesity, and smoking. You can see that there are differences between the subgroups, and the different colors are for different genders. So the maroon color is for women and the blue color is for men. So some, broad kind of take-home points from this are that, for example, Filipinos and South Asians tend to have higher rates of diabetes than the overall Asian category if you compare them to all Asians, whereas the other subtypes, subgroups of Asians tend to have lower diabetes risks. If we're looking at hypertension, the results are a little bit mixed and a little different than what the data would suggest if you study people in their native homeland. So if you study people before they've migrated, and I'll touch on that. But in Asian Americans, at least in this study, Filipinos tend to have higher blood pressure than the other subgroups. And then when you see this, which is neither an up or a down, this means equivocal. They're about average risk for South Asians. With respect to coronary disease, again, South Asians are higher risk than the other populations, and Filipinos, at least men, are higher risk, and women are maybe, kind of average risk when compared to the other Asian groups. When we look at obesity rates, again, Filipinos and South Asians are more likely to be obese, but interestingly, Japanese are more likely to be obese than some of the other subgroups. And then smoking rates, there are certain groups that tend to smoke more than others. So the Korean patients and patients, Filipino patients, also Japanese women, and in this study, not Japanese men, though there is other literature to suggest that Japanese men also smoke maybe more than, at least when you compare them to non-Hispanic whites. Now, this is another busy slide, and I'm going to walk you through it. So I'm not sure if you can see all the detail, but what this shows us is death rates per 100,000 for stroke on the left-hand side and death rates for coronary heart disease on the right. So let's focus our attention to the left to start off with. These different bar graphs, bars on the that run down the graph are different countries. And so these white bars are the Western countries. They're countries like the United States, the UK, Spain, New Zealand, France, Australia. What you can see is that these gray bars that denote Korea and China, people from countries such as Korea and China typically have higher stroke risks than people in Western countries like the United States. Japan used to have really high stroke risks as well, probably higher than some of these Chinese rates observed. But interestingly, in the 1960s, the government launched a really aggressive public health campaign and really worked to reduce people's sodium and salt consumption. And with that, people's blood pressures really improved, and so did their stroke risk. Now, if we look over on the right-hand side and look at coronary heart disease, so no longer stroke, but actually, things like heart attacks. Again, if we look at the white bars, those are, again, the Western countries, so the United States, UK, Spain. I want to draw your attention to a couple of things here. One, if we look at those gray bars that we already looked at, so East Asians, Korea, Japan, China, they tend to have lower heart attack risk and cardiovascular mortality than non-Hispanic whites. And then if you look at these dark black bars here, these are individuals that hail from South Asian countries, Pakistan, Bangladesh, and India, and they tend to have higher rates of coronary heart disease. So I bring all of this to your attention to tell you that, again, if we just rely on the aggregate data that often studies present or government data presents, we are really missing some of these meaningful differences between these groups. And then it becomes harder to target our, our efforts when we're thinking about prevention. So when I look at this data, this tells me that maybe I need to focus more on lipids and things in some of the South Asian populations, and perhaps we think blood pressure is an more important risk factor in stroke, that we should be focusing on blood pressure in the Koreans and Chinese, for example, if I take the data from this study. It's important to have this data because it helps guide, it helps inform you and helps guide your preventative measures in the future. So hopefully I've built the case for a need for an era of precision medicine and personalized care. I think we can no longer just treat everybody with a one-size-fits-all approach. I think it's important to look at people in terms of their ethnic and cultural backgrounds, look at their socioeconomic status, look at their gender, all of these health determinants, and then personalize our care, a patient's care based on that, or customize their care. So I'm going to shift gears a little bit now to talk about South Asians and heart disease. So you may wonder, well, what does South Asian refer to? So South Asian refers to an individual who hails from the countries that I've circled here. So Pakistan, India, Nepal, Bhutan, Bangladesh, Maldives, and Sri Lanka. South Asians, as I've already shown you some data, are at increased risk of cardiovascular disease. So in India alone, for example, in 2011, 17 million people died from cardiovascular disease, and 3 in every 10 deaths occurs from cardiovascular disease. South Asians are also disproportionately affected by coronary disease. So, by 2020, so by last year, South Asians made a quarter of the world's population, and yet they bore more than 60% of the coronary artery disease burden. So really disproportionately affected. If we look at data closer to home, if we look at data from California, we can see that Asian Indians have higher rates of hospitalization for heart attack and stroke when compared to whites, but also when compared to other Asian subtypes such as Chinese, Japanese, and Filipinos. They're 4 times more likely to have cardiovascular events. The other thing that always strikes me is that, in the past, I think, and a lot of people, I think, do think that heart disease is a disease of the elderly. But if you look at the presentation of South Asians, at least with heart disease, sometimes these patients are quite young. So more than half of first heart attacks in South Asians happen below the age of 50. And if you look at this gray bar here, a quarter, so 1 in 4 heart attacks in South Asians happen below the age of 40. So really quite young patients. So South Asians develop coronary disease on average 10 years younger or earlier than their Caucasian or European counterparts. They tend to have more severe coronary disease at presentation and more likely to have sort of multi-vessel disease, more than one blood vessel that's involved. And they have higher mortality or death rate after their first heart attack. Now, why is that? Well, it's because of all those risk factors that I've already talked to you about. So the same risk factors remain important. If we look at South Asians, they're much more likely to have diabetes and some of these precursor stages to diabetes. So South Asians have higher fasting insulin levels and higher rates of insulin resistance. South Asians also have a twofold prevalence of type 2 diabetes and a higher prevalence of impaired fasting glucose, or pardon me, impaired glucose tolerance, which is one of those pre-diabetic sort of states compared to non-Hispanic whites. The other issue is that South Asians develop a lot of these sugar issues, insulin resistance, prediabetes, diabetes, and even coronary artery disease at lower BMIs. So BMI stands for body mass index, and it's a ratio of your weight to your body surface area, and lower is generally better. So, most other, at least non-Hispanic whites, for example, are considered to be normal weight if their BMI is less than 25. But the World Health Organization has proposed lower BMI targets for certain Asian groups, including South Asians, where normal is less than 23. And a waist circumference cutoffs are also different for South Asians. The other interesting observation is that South Asian women, although they usually have lower pre-pregnancy BMIs than Caucasian women, they're more likely to develop gestational diabetes. If you look at body composition of South Asians, it gives us some clues. So this graph shows us the waist to weight ratio for different ethnic groups. That means, looking at the same weight, we're looking at how big somebody's waist is. And that usually tells us that they have, if you put on central fat or you have central obesity, that kind of fat we think is more biologically active or metabolically active, more likely to lead to chronic inflammation and insulin resistance, more likely to coat your visceral organs, and lead to things like heart disease. So, these, again, bars represent different ethnic groups, and the South Asians or Asian Indians are indicated by this kind of teal or light blue color here. You can see that both men and women for the same weight have larger waist circumferences when they're South Asian compared to Caucasians, compared to Mexican Americans, and compared to African Americans. And the problem is that this condition of insulin resistance, obesity, starts quite early. So this little guy is having his mean skin fold thickness checked. This is a way that you can check for body fat percentage or adiposity in babies. And what they have shown is that South Asian babies have increased fat content. So even at the same body weight, if you standardize for body weight, the white kids, the white babies are the ones in the blue, and South Asian babies are indicated by the black. South Asian babies tend to have higher skin fold thickness, which indicates they have higher fat content. And this has been shown to predict later problems in life, more likelihood of developing metabolic diseases like insulin resistance and diabetes. Another reason South Asians develop coronary disease at high rates is that they have cholesterol abnormalities. But they seem to, a lot of South Asians, especially in living in Western society, seem to have this unique pattern of lipid abnormalities where they have very high triglycerides and low HDL. It usually goes hand in hand with their insulin resistance. And sometimes, and quite often actually, their LDL is not that strikingly abnormal. But if you look at beyond the LDL number, if you look at the particles themselves, the LDL particles are abnormal. They're smaller and they're lower density. And these are the type of LDL particles. And when I say LDL particles, that LDL is your bad cholesterol. So even if their LDL concentration isn't that high, the particles they have are more damaging. And just for those of you who don't know, the HDL is your protective or your good cholesterol. So they have less of their good cholesterol, more small or dense LDL, the bad cholesterol, and higher levels of triglycerides, which are also a risk factor for heart disease. So I'm going to do a time check. What can you do to prevent heart disease? I want you to take away, be able to take away some things that you can actually do to change your own risk here. So, the key to changing your risk is, first of all, understanding your risk. So it's really important that you understand what your blood pressure is, what your cholesterol numbers are, find out if you have diabetes or pre-diabetes, and learn your family history. because there are things that run in families and people can have a genetic predisposition to developing heart disease. Also, if you're a smoker, one of the most important things you can do to lower your heart attack risk is to stop smoking. And then, if you look at this list and the list of the important risk factors that I've told you about, you can see that the vast majority of them are modifiable. That's the good news. So even if you have these risk factors, a lot of them are in your control. Of course, family history is not. You're born into the family that you're born into, but everything else, aggressive lifestyle measures can really make a big difference. So I want to talk about a few things that you can do. So exercise, I think this is not something that gets enough attention. And I think in a busy clinical practice, when a doctor is seeing you, they often don't have the time to sit down and talk to you about how much you're exercising. But I want to show you some data that hopefully will convince you that you do need to exercise. So you've probably heard this term or this adage, sitting is the new smoking. And this comes from some data from studies, actually studying more than 1 million adults over 45 years old. What they found was that if for those individuals who sit a lot, so if they sit more than 8 hours a day, and if they exercise very little, which means about 5 minutes a day or less, their death rate was as high as those individuals who were smokers or the individuals who are obese. So the sitting carries the same risk as smoking or being obese. Now, if you, on the other hand, have that type of lifestyle, a lot of us do right now with the COVID pandemic, people are working from home and sitting in front of their computer. If you take the time to exercise, if you get 60 minutes of moderate intensity activity in per day, you can negate that added risk that comes with sitting. There is a lot of data to suggest that exercise is good for you. This is another study where they looked at fitness level patients. So they brought them in and said, exercise for me on a treadmill and let's see how far you go. And then over time, they followed them to see people's death rate. And what they found was that these individuals, quintile 1 are the people who were able to go the least amount of time on the treadmill. They only achieved 1 to 6 METs. Which is a way we grade workload when you're exercising on the treadmill. Their death risk was the highest. And you see this kind of linear relationship. Those individuals who exercise the most or were able to go the longest on the treadmill had the lowest death rate. And what was also interesting was that this relationship held for normal individuals, as in people who've never had any heart disease, but also individuals who already have established cardiovascular disease. So if people already have had a heart attack and stroke and they're worried about their risk and trying to figure out what they can do, you can see that really increasing your fitness level and being regularly active can really bring down your death risk or your mortality risk. So this is another issue that I deal with a lot in clinic. When I see my patients, people are often complaining that they just don't have the time to exercise. Of course, with our busy Bay Area lifestyles, I get that. It's hard to fit in exercise on a daily basis. But I think you can take some part in this data then. So if you look at people's activity level and their mortality, which means death rate, from cancer in the blue, or from cardiovascular disease, so from heart disease in the maroon, what you can see is that patients who are inactive, so those are the patients at the bottom of this graph here, have the highest level of mortality. So they're more likely to die from cancer or from heart disease than everybody else. People who are regularly active, so those are individuals that are getting in their 30 minutes of exercise 5 days a week, have the lowest mortality, both from heart disease and cancer. But what is really interesting is that these weekend warrior types, so these are people who don't have the time to exercise on a daily basis, but they take a day or two in the week and they give it their all. So they get in 75 minutes of what we call vigorous exercise on the weekend or some other day of the week. They are able to get their mortality rates not quite as low as the regularly active folks, but almost there. So, if you can exercise daily, remember this graph and see if you can get some vigorous exercise in at least once or twice a week. Now, bringing back our ethnicity lens and looking at how different cultures perceive exercise or how much they value exercise, I think this is going to present some interesting data to you. So this is a study out of China looking at Chinese adults and their physical activity. They studied about 15,000 patients, and this was survey data. And on first glance, it looks pretty good. So overall, most patients were not too badly. 60 to 75% of patients were getting daily exercise in. And again, they classified this as 30 minutes of exercise per day. Of course, as people get older, they got a little less active. But if you break this down to rural living Chinese and urban dwelling Chinese, what you see is the people living in the rural environments are by and large the ones that are active. The people living in urban environments, like most of us, sitting in front of our computers or sitting in a desk job, they were really inactive. So between 9.8 and 28% of those folks were active. So this, gives you some reason to pause. So if you think about the way the world is changing and demographics are changing and how, Eastern cultures and Eastern countries are becoming more urbanized, you can imagine that as these people move from rural environments to more urban environments, their activity levels may change. And as people get more sedentary, that's where a lot of these other problems that I've talked to you about, the obesity and the blood pressure, cholesterol, sugar issues all come up. I thought this was really interesting also. So this is, again, the same study, and the black bars are the rural people, the white bars are the urban people. And you can see the difference between the rural and the urban folks. But if you look at where people are getting their physical activity in, you can see that largely people are getting their activity, even the really active people, the people who live in rural environments, they're getting all of their activity in at work, their work-related tasks, and they're not really spending a lot of their leisure time at all on physical activity. So this tells you where people prioritize things, right? What you do in your leisure time is what you usually value. And again, it's concerning because it's not like these rural dwelling people are actually really looking forward to exercise. They're just doing it because it's required of their occupation. And you think if people change occupations, become more urbanized, this may lead to all of the problems that industrialization and Western way of life brings along with it. South Asians also do not have high levels of exercise. So if you look at South Asians, even if you look at South Asian children, so there's some interesting studies done out of the UK where they put accelerometers or pedometers to check people's number of steps in a day. And they put these on Black kids, white kids, and South Asian kids in the UK. And what they found was that when people were at school, all of the kids ran around the same amount of time, had the same number of steps. But when the South Asian kids got home, they were much more sedentary and got much fewer steps in than the other ethnic subtypes. When you do look at survey data, only half of South Asian participants say that they meet recommended guidelines for leisure time physical activity, and less than 50% of those surveyed even recognize that exercise is a way to prevent heart disease. So I think we need to raise awareness before, that's a big part of the piece when we're trying to make these changes. So what else can you do? Well, the American Heart Association came out with Life Simple 7 a few years ago. And I think this is something that is really easy for people to follow, and something that you can maybe print out from the AHA website and kind of keep on your radar. So we've talked a lot about this in blue, get moving, right? We've talked a lot about exercise and the importance of exercise. You can see that a lot of these, however, are linked. So if you get moving, for example, if you start exercising a lot, you're likely to lose weight. If you start eating right, and we'll talk a little bit more in detail about diet, you'll also likely to lose weight. If you lose weight, this is, obesity is a common pathway. People develop issues with blood pressure, cholesterol, and their sugars. So if you lose weight, you're more likely to not be diabetic or improve your sugars. You're more likely to control your cholesterol, and you're more likely to manage your blood pressure. And then, of course, never forget about stopping smoking. So still 19% of men and 15% of women are smokers in this country. And I think, out of the important things you can do to promote your heart disease risk, if you're a smoker, stopping smoking is number one. So what do we mean by eat better? Well, there's a lot of diets out there that have been shown to improve cardiovascular outcomes. The popular ones that you might read about are the DASH diet or the Mediterranean diet. What a lot of these diets have in common is that they really encourage high intake of vegetables, fruits, whole grains, beans, legumes, nuts. When you're getting your protein, try to make it plant-based as much as you can. But if you are having animal proteins, then lean animal proteins and skinless poultry and fish. You really want to limit your sweetened drinks, your processed meats, your refined carbohydrates, any kind of processed foods coming out of packages are not good for you. And you want to limit full fat dairy, replace it with low fat dairy, and limit tropical oils like coconut and palm oils. And then you really want to avoid these commercially baked goods that have a lot of trans fat and partially hydrogenated oils. You can start reading nutrition labels. It's a good way to start. I mean, you don't need to necessarily do calorie counting, but paying attention to sodium content of foods, how much added sugar there is in foods, those kind of things are a good first step. And then when you're thinking about going beyond calorie counting, if you think of a 9-inch plate, some general rules are make 50% of that plate your vegetables, only a quarter of it your grains, and you make sure you pick whole grains, not refined and processed grains. And the last quarter is your protein. Get moving, we've talked about this extensively already, but your activity goal should be 75 minutes of vigorous activity in a week. And that would be things like sprinting, playing basketball, playing soccer, those sorts of things, or 150 minutes of moderate intensity exercise per week. You can split that up through the week, and vigorous and moderate intensity would be a brisk walk that would qualify. How to manage your weight. Again, a lot of these things are linked, right? If you get more active, if you follow a healthier diet, you're more likely to lose weight. Also, knowing where you stand, knowing what your BMI is, what your target weight is really important, because if a lot of people don't even realize that they're overweight, and remember that for different ethnicities, there's different goals in terms of BMIs and what's important and what's normal. Okay, and then I want to leave some time for questions, so I'll quickly glean over this. Some common questions that have been coming up in clinic are about medications and supplements that people can take, and people want to know if they should take them. So the first one that comes up a lot is, should I take aspirin? And the reason I think this comes up is that there were some important headlines the last couple of years about low dose aspirin and whether or not people actually need it. So I will say, as a cardiology community, in the past, we have used aspirin for primary prevention a lot more than we do currently. So I think there were some important studies in the last few years that have shown us that you have to treat a lot of people in the primary prevention category is what I'm saying. So that's people who have never had a heart attack or stroke, because those people are not as high risk as people who've already had coronary disease. If you've already had a heart attack, this does not apply to you. You definitely need your aspirin. But for people who've never had an event, what we learned is that you need to treat a lot of people to reduce, one heart attack. Also, the benefits that you gain from thinning somebody's blood and reducing heart attacks is often offset by their bleeding risk. So this is, again, where precision medicine, personalized care becomes really important. It doesn't mean that nobody needs daily aspirin for primary prevention, but I think a detailed discussion with your provider, understanding your risk, both of a heart attack or clotting issues and your risk of bleeding, will help you determine whether you should be taking aspirin or not. Another question that comes up often is, should I take coenzyme Q10? So we used to use coenzyme Q10 a lot more. I felt like when I was training, we were using it a lot more because we thought it might help people who were taking statins, which are a class of medications to lower your cholesterol. We thought that perhaps statin-related muscle symptoms that some patients experience might be lessened or lowered by taking coenzyme Q10. But the data is lacking, and the American Heart Association has put out a statement on this and concluded that coenzyme Q10 is not helpful in reducing statin-related muscle symptoms. And And there's a whole host of other supplements that people always ask about. I'll touch very briefly on a couple of these. So fish oil, we know that omega-3 fatty acids are generally good for the heart. They lower triglyceride levels. So for, I don't think any of these are a substitute for a statin. So if you are considered high risk by your provider and they've said you should be on a cholesterol medication, I don't think that this is a substitute, but there are certain patient populations that might benefit for some of these supplements. And fish oil is a good one. There are other things that are maybe have not as strong evidence behind them. So fiber, dietary fiber, and psyllium husk fiber, so what you get from Metamucil, for example, has been shown to lower your LDL modestly, not by a lot, but it can make a difference. Plant sterols and stanols also can lower cholesterol by lowering your absorption. And then red yeast rice is another kind of supplement that works similar to a statin, though there are concerns about, none of these agents are regulated the same way as medications are. And so you could be taking something without knowing whether it's completely efficacious. And there's also some concerns about potential toxicities of at least the red yeast rice that I don't have enough time to talk about. Okay, so to conclude then, hopefully you've taken away from this talk that heart disease is the leading cause of death in the US. Asian population is diverse with important differences in ethnicity, cultural practices, their lifestyles, migration histories, and socioeconomic factors. Some subgroups of Asians are at particularly high risk for heart disease due to their increased vascular risk factors, for example, South Asians. Other subgroups are traditionally thought of as low risk, but they may be lower risk for heart disease, but you have to pay attention to their vascular risk factors. And for example, I showed you some data suggest some East Asians may be higher risk for stroke. Also, as people migrate, their risk changes and they often adopt the risk of their host countries. So I think this is really important research. I think we are learning, and we're really early in our understanding of heart disease and heart disease risk in Asians, but an important area of study. And finally, I think the big takeaway is that most of these risk factors are modifiable, so they are in your control. If you get active, if you lead a healthy lifestyle, you can really change your risk profile. And with that, I'll stop and open for questions if we have any.
Great. Thank you. Thank you so much, Dr. Josan. That's fantastic. Really excellent talk. Packed full of data and useful information. It's amazing you were able to get through that in 52 minutes. We do have a lot of questions.
Okay.
From Mary Smith. How early do we need to make dietary changes? My mother-in-law insists I'm too young to worry about this. I'm in my 40s and in good health.
Great question. So I showed you that data of the slide where children are starting to, people between the age groups of 12 and 19 are starting to develop obesity, develop sugar problems, cholesterol problems, blood pressure problems. So I don't think it's ever too early. I think you should teach your children healthy lifestyle and healthy eating habits. And somebody in their 40s is definitely not too young to adopt these.
Great. Yeah, never too early. Fantastic. From Jill Tanaka, is there a test I can take to know if I've inherited this? So I assume cardiovascular disease in general. Is there a genetic test? Is there a test for this?
I would say not really. There are, so first of all, you can see that there's so many important pathways and risk factors that are important. So you may have a genetic risk for developing one risk factor versus another. There are certain, tests you can do, for example, checking a lipoprotein A level, which is a heritable risk factor. It's a lipid parameter. And when it's high, it's something that you can't control with your diet or exercise or anything. So that's one, but that doesn't cover, that doesn't fully explain all heart disease risk. So the short answer is no. I think that you kind of need to take all of this information together, all of your different risk factors, your family history. And sometimes we can use, imaging modalities and other testing to kind of figure out your risk, but no easy, quick, like genetic test that'll say, yes, you have it or you don't have it. Because again, some of this is genes, but a lot of it, hopefully you can appreciate, is lifestyle, and you can really alter your risk based on lifestyle.
Thank you. Next question from David King. Interesting question, kind of related to immigration. Do these risk factors worsen for Asians who adopt a Western lifestyle?
Yeah, good question. So there's certain things that seem to worsen. So most Asian groups, when they migrate to the United States, they tend to follow Western diets, which are often higher in saturated fats and higher in calories. So most people put on weight, and so they can develop lipid issues. And so the Japanese population is an interesting one, for example, because they do show increased BMIs compared to people in Japan, and increased lipids, and increased coronary heart disease risk. But some things can get better. So for some reason, some of the Asian countries, as I'd mentioned, have higher hypertension rates, and it might be related to dietary practices and sodium intake. And at least I've seen some literature in the Japanese population that their awareness of hypertension is higher in the United States, and therefore their blood pressure is better controlled. So you might be gaining some risk and maybe offsetting it by other things.
Great, thank you. From Vijay Ayeki, has something changed with the risk factors in Asians? Vijay mentions he doesn't recall this being the case when he was younger. Is it more about education? We're more aware, or has something changed over time?
Right. So I think that there's a lot more awareness. So, if people, I think a lot of folks now realize that, for example, the South Asians are high risk, whereas people were dying from heart disease and people just didn't have the data perhaps or the awareness before. The other thing is that as all of us adopt more Western industrialized sort of lifestyles, we all become higher risk. So generally we're not as active as we should be, and we're eating too much and too heavy. So there may be some change with just the type of lifestyles we've adopted, but also there's a lot more awareness and more research being put into this field.
Great. More research, always better. From Dhiren Patnaik, sorry, I apologize if I mispronounce your name. If cholesterol is within range, does it mean a person is healthy?
I would say that no, I don't think you can say that. I think you can say that. So for example, to answer your question, you could have a normal or healthy cholesterol, but your blood pressure may be really high. You may have insulin resistance, or you may have diabetes. And so I wouldn't classify you necessarily as healthy just because you have normal lipids. The other thing that I didn't really talk very much about is that your lipid targets really depend on your risk profile. So for example, people will come in and say, my lipids are good, but if you've had a heart attack or stroke, we treat you very differently, and you have much lower targets for what your LDL, your bad cholesterol should be than a person who's never had heart disease or an event. So that's but to answer the person's question, I think that's just one piece of the puzzle. I think health is much more broad than that.
Great. We have multiple members of the Solis family watching. What actionable steps can we take to encourage Asian American immigrants to improve their diets, especially if these are culturally enforced?
Yeah, so it's hard to change kind of behaviors. Behavior modification is a business that's not for the faint of heart. I mean, I try to do it all day long in my practice, but I will say that it starts with awareness. So a lot of times people are just used to doing things because that's what their parents did and that's what their grandparents did, and you don't question it. But I think if you start seeing people have bad events, and you start seeing, and somebody presents to you the data and shows you what your risk is, that can go a long way. So starting with education is a big step.
Great. And next question, concerning diabetes, what do these data mean for rates and treatment of gestational diabetes in Asians?
I think they tell us that certain subtypes, particularly Filipinos and South Asians, tend to have higher rates of diabetes and gestational diabetes, probably related to their higher obesity rates. So one being, I think it's important that once we know that that's a risk, people understand their personalized risk, find out if they're overweight, and try to modify that. For example, for women trying to get pregnant, trying to achieve a healthy body weight before you get pregnant can lower your gestational diabetes rate, which can have important consequences for your child, right, as well, and the health of your pregnancy. So I think they tell us that our lifestyles have a lot of improvement to be made. There's a lot of improvement to be made.
Great, thank you. I'm going to claim the last question for the last minute. Coronary calcium scores. who should get coronary calcium tests and who should not? Is it useful? And I guess maybe explain a little bit about what it is as well.
Sure, that's a great question. So coronary artery calcium scoring is something that we do by way of a CT scan. It's a test that, it's a quick scan. You don't require an IV, you don't require contrast to be administered. And what we're really looking for is just the amount of calcium that has built up in the coronary arteries of the heart. And where there's calcium, there's atherosclerosis or hardening of the arteries and accumulation of lipids. So this is a nice way sometimes to determine somebody's risk when you're not sure of their risk. So I would say in terms of who should get it, I think if you already know you're high risk, you have already had a heart attack or stroke, don't bother getting it because you're high risk. We're going to treat you as aggressively as possible. If you are low risk, and particularly for people under the age of 40, coronary calcium scoring isn't great because sometimes they can, usually you need to be around for long enough, and your atherosclerosis needs to be around for long enough to have calcified. So most people under 40 won't have a lot of coronary artery calcium. Where it's useful is people who are intermediate risk. So people who are on the fence and you're trying to figure out, should we put you on a cholesterol lowering agent or not? Should we put you maybe on an aspirin or not? And if we, your numbers are borderline, but then we scan you and you have a ton of calcium in your heart and we compare you to other people your age, your gender, and your score is much higher than theirs, then that would suggest that we should be aggressive with you, maybe put you on a statin. And sometimes we think about aspirin. On the other hand, you had borderline numbers and then your calcium score is 0, your arteries are beautiful and clean. You can say, well, this buys you kind of a warranty period. Most people with a 0 calcium score do really well over the next 3 to 5 years. And so most doctors would withhold treatment in that case.
Great. Well, thank you so much for joining us. Thank you for that enlightening talk. I'm sure, and I believe you're still seeing patients. Is that correct? And so if you have a referral, I'm sure you can see Dr. Josan if you need to. And really appreciate all the audience for joining us today. This webinar is recorded, so we will also promote that as well. And please join us next month for Dr. Juha Huang, who will be talking about gastrointestinal disease in Asians. Thanks for joining us, and thanks again to Dr. Josan.
Thank you so much.